All right, if you could stop sharing so I can put my slides up. Okay, can you see my slides?
Yeah.
Okay, well, thank you very much for the invitation. And what I was asked to talk about was to really focus on hormone receptor positive metastatic breast cancer with a specific focus on the PI3 kinase pathway. And there's been a lot of activity in terms of drug development in this area, and it continues. And what I'm going to talk about tonight over a short time, and then, of course, we'll have some time for questions, is how we approach these patients and the importance, as you already pointed out, of precision medicine in making our decisions. If you look at this graph, just sort of as a backdrop to the talk we're going to hear, we know that in hormone receptor positive disease, that we've made a lot of progress in terms of improving overall outcomes. And on the next couple of slides, you'll see why, because I think it's not only that we have better treatments for early stage disease, but we also have much more effective therapies for advanced disease. And the same is true in in HER2 positive disease. And our advances in triple negative disease are a little bit slower, as you can see on the far right. But in hormone receptor positive disease, we've done a great deal of advancement, particularly in the last few years, with the introduction of many different SERDs and targeted therapies and more that are coming. And this puts it in perspective. When I started training, which was really when I started practicing, which was in the 80s, you can see that not a lot was going on with respect to endocrine therapy. We had tamoxifen, we had fulvestrant, we had the aromatase inhibitors, and then not a whole lot happened. And then over the last decade, we've seen innumerable drugs that have been introduced. Most of them were targeted therapies that could be combined with endocrine therapy. We saw the PARP inhibitors come online. And then, of course, more recently, we've seen antibody drug conjugates, which have significantly improved the outcome of patients who grow refractory to endocrine therapy. And in a single slide, you can understand, I think, the importance of how we think about hormone-sensitive breast cancer. We know in the first-line setting that we still rely to a great degree on CDK4/6 inhibitors combined with endocrine therapy. We know that endocrine therapy is used in the adjuvant setting, and on high-risk patients, CDK4/6 inhibitors are being used more commonly. And there are also one subset of patients up on the far right, and we'll talk a little bit more about that in a moment, but who have rapid progression on adjuvant therapy and also have a PI3 kinase mutation where we consider a triplet of therapy with fulvestrant, a CDK4/6 inhibitor, and a novolisib, which targets the PI3 kinase pathway. And until recently, really the last couple of years, we've relied on molecular testing of the tumor, ctDNA, or even tissue examination in the second line and beyond. But now we start doing it right away, right when a patient is diagnosed with metastatic disease, because we might identify patients who need a targeted therapy as their first-line treatment. But for most patients, we're making decisions with targeted therapy in the second line and beyond if they have particular mutations. A CDK4/6 inhibitor, of course, you don't need a mutation, but for certain drugs, like the SERDs, we may need to know whether or not a patient has an ESR1 mutation, or we may need to know if a PI3 kinase AKT/mTOR pathway abnormality is present, which would justify the use of a PI3 kinase pathway agent, and we'll be talking about that tonight. And then when you get to the third line, again, we start to see that there may be some endocrine options. Obviously, if a patient has a BRCA mutation, we'd use a PARP inhibitor, but we start to see the introduction of cytotoxics, either standard chemotherapy or antibody drug conjugates. And we'll talk a little bit about that at the end in terms of the trials that have shown benefit from antibody drug conjugates. It's the standard of care now, and it's in guidelines, ESMO guidelines, ASCO guidelines, that we should be doing multi-gene panel testing in patients with metastatic hormone receptor-positive disease. And the reason is, as shown in the table, we have a lot of drugs that are potentially useful for patients who have particular mutations. And although we're not going to be talking about RET fusion or NTRK fusions or BRAF, which are quite uncommon, the others are much more common. PI3 kinase AKT, PTEN abnormalities, ESR1 mutations, which are common. So we need to know that in terms of optimizing a patient's treatment. In the NCCN guidelines, and I chair the NCCN guideline panel, we have clearly outlined the reason why we need to know this information. So obviously, if somebody has a PI3 kinase activating mutation, we have drugs like inavolisib, alpelisib, and if they have a PI3 kinase or AKT mutation or a PTEN mutation, then capivasertib may be an option for patients. And we're not going to really talk too much about ESR1 mutations, which is a whole nother topic. But of course, we have several drugs, elacestrant, imlunestrant, and even vepdegestrant, which was just approved in the United States in the last couple of weeks. So just a couple of comments about some of the common mutations. We know that ESR1 mutations are largely acquired mutations. They're something that occurs over time under pressure of treatment. So if you were to look at a primary tumor in a patient with a newly diagnosed breast cancer, most patients will not have an ESR mutation. It's quite uncommon. However, if a patient undergoes a treatment with endocrine therapy and they get repetitive different kinds of treatment over time, the likelihood of developing an ESR mutation rises significantly to up to 40% in some series. So it's important to know that because, of course, we have drugs that can target that. And you can look at this in this particular experience that was presented several years ago. And we know that in patients who are receiving a CDK4/6 inhibitor with endocrine therapy, if you look at patients before treatment and after treatment with a CDK4/6 inhibitor, you start to see many more patients who are developing ESR1 mutations. And there are also, a few patients who have these unusual RB1 abnormalities. But again, most of the other things are not targetable. And we'll talk about PI3 kinase mutations because this is something that we view as truncal, something that is there right from the beginning. So if you were to interrogate a primary tumor, you're going to see 30 to 40% of patients who may have a PI3 kinase mutation right at the time of diagnosis, which is markedly different than what you see in looking for ESR1 mutations, which are uncommon. So important to know. So this in a single table summarizes what we all know, and that is that the CDK4/6 inhibitors as a first-line therapy are very effective. We've seen that they can significantly improve PFS and in some cases actually survival, particularly with ribociclib, more so than abemaciclib and palbociclib. And there was also a marked improvement in PFS, even if they were used in the second-line setting. In the US and likely in China as well, most patients are getting a CDK4/6 inhibitor first. They're not waiting. So once patients progress after having a CDK4/6 inhibitor, the question becomes, what do you do with the patient? Well, as I already mentioned, we could look for whether or not an ESR1 mutation is present, which would open up the possibility of using a SERD with or without a targeted therapy attached. And we're not talking about that tonight. Or we can look for a PI3 kinase pathway abnormality. And there have been several drugs that have been looked at in that space, the oldest being everolimus, which is somewhat distal to PI3 kinase. It's an mTOR inhibitor. And in the early trials, now quite old, it was clearly demonstrated when you add everolimus to endocrine therapy, you significantly improve PFS. And an mTOR inhibitor like everolimus is still something that is useful because you don't need a target for that. So you're not looking for a particular mutation. Whereas if you have a PI3 kinase pathway abnormality, we now have a variety of drugs, including the older one, alpelisib, which was demonstrated to be effective in patients with mutations, where if you add a mutation, adding alpelisib to fulvestrant compared to fulvestrant alone doubled the time until disease progression. So for a while, this was the go-to drug, and we know that obviously alpelisib can have some issues with toxicity, and we'll talk about that in a bit. And then we saw, based on the Capitello 291 study, that if you have abnormalities in the it's viewed as an AKT inhibitor, but if you have PTEN abnormalities or PI3 kinase abnormalities, you were also eligible to participate in the trial. And we also saw that there was a significant doubling of the PFS for patients who received this drug. And as I'll suggest, the toxicity profile is more favorable than what we see with alpelisib. And this is the Capitello trial, which you're familiar with. And these were patients with hormone receptor positive, HER2 negative disease, who had developed disease recurrence and had fewer than 2 lines of prior endocrine therapy and up to 1 line of chemotherapy. And the trial was designed so that at least 50% of the patients had been exposed to a CDK4/6 inhibitor. And the patients in the trial didn't necessarily have to have a PI3 kinase pathway abnormality, so they were looking at both wild type and those with an abnormality. And the randomization was between fulvestrant capivasertib or fulvestrant placebo. And the demographics of the patients in this trial are outlined on the bottom. And about a quarter of the patients were Asian. Median age was about 60. Primary endocrine resistance was almost 40%. So that is patients who just went right through their first endocrine therapy. And about 75% of the patients had 1 line of endocrine therapy in the metastatic disease setting. And 70% of the patients had received a CDK4/6 inhibitor before. And there were only about 18% of patients who got prior chemotherapy. So if you look at the median PFS when it was first reported, there was more than a doubling of PFS when capivasertib was added to fulvestrant, going from 2 months to 5.6 months. And you can look across a variety of different clinical parameters, and whether you're looking at age or where the patients came from in the world, whether they were pre or postmenopausal, where their mets were, whether they had prior CDK4/6 inhibitor or not, or chemotherapy or not, the patients who got capivasertib did much better. Everything is to the left of 1, so the forest plot really suggests that there is no specific patient who didn't appear to benefit from the addition of capivasertib to fulvestrant in that setting. And to break it down even more and look at it in a more granular way, if you look at patients who had a prior CDK4/6 inhibitor or not, which is on the top up here, or patients who got either a shorter duration of exposure to a CDK4/6 inhibitor or longer duration, there was benefit from receiving the capivasertib added to fulvestrant. So again, all of these parameters, it didn't make any difference. Patients were benefiting from capivasertib. If they got prior chemotherapy or not, there was an improvement in outcome. The magnitude of that benefit was greater if there was no prior chemotherapy, but even in the patients who had gotten chemotherapy, 18% of the entire trial, there was an improvement in PFS. Whether you had liver mets or not, there was an improvement. Better to not have them. The magnitude of benefit was greater. So you can look at all of this information put on a single slide. And again, the forest plot is very much the same. There was a clinically meaningful improvement in PFS for all groups that were analyzed if you received capivasertib added to fulvestrant. Now, since then, there was also a trial looking at the triplet, which I alluded to earlier, for patients who had sort of bad acting disease. That is, patients who had progression during or within 12 months of adjuvant endocrine therapy being completed. And these were patients who were randomized to enovolisib, which was a selective PI3 kinase inhibitor, And it also promoted degradation of the mutant P110 alpha subtype. And they were randomized between the triplet and palbociclib and fulvestrant with placebo. And in this trial, which had 300 patients, there was a 1:1 randomization, clearly demonstrating that in these bad-acting patients, that the improvement in PFS was doubled, going from 7 months to 15 months if enovolisib was added. Now, again, these are patients who are rapidly progressing through their adjuvant therapy. Now, it's never fair to put the side effect profile on a single slide because these aren't direct comparisons, but you can look across these different trials and get a sense of the difference in toxicity. So again, alpelisib, which was sort of the first drug we had available, hyperglycemia is particularly a problem, and even with enovolisib, you're still seeing a significant fraction of patients with any grade hyperglycemia, whereas if you look at the Capitello trial, it's markedly decreased. Diarrhea can be a bit of a problem with capivasertib, so you have to warn patients about that, and there is a little bit more of that than what you see in the other trials. But the other common things that's seen with the other pathway targeting agents like enovolisib or alpelisib is you're also picking up a fair bit of stomatitis. And again, this was much less with patients who were receiving capivasertib. You have to be aware that patients can experience nausea, and you have to provide them antiemetics if they run into that problem. You have to warn them about concerns about stomatitis or rash to contact you so that you can, mitigate those, manage those so that patients stay on treatment. So again, just sort of summarizing in even a more simplistic way. And the other important point is, as you look across these trials, some were more rigid than others in terms of hemoglobin A1C to get into the trial. And in the capivasertib trial, Capitello 291, hemoglobin A1C was allowed up to 8%, whereas the others were less. And again, hyperglycemia rates are markedly less when you look at that compared to the other options. And again, one of the more recent drugs, which we're not going to spend a great deal of time on, it was updated at ASCO this year in study 2, was gedatolisib, which is an IV medication that also targets this pathway, the PAM pathway. So again, differences in toxicity between the drugs. Generally, capivasertib has manageable side effects with relatively few patients having grade 3 toxicity. But again, you have to be aware particularly of diarrhea and rash, which can occur, and not only be aware of it, but provide patients with management tips and encourage them to contact you early so that you can manage it and keep patients on treatment. Now, if we pivot to those patients who have gotten through their anti-hormonal therapy and you don't feel that they're candidates to continue on any other anti-hormone therapy. And again, what I was asked to talk about tonight was very specific. So we're not talking about SERDs. So if somebody had an ESR mutation and they had gotten, they were still viewed as a candidate for endocrine therapy, then a SERD would be considered either alone or with another agent. So that could be elacestrant, imlunestrant, and then, of course, very recently, vepdegestrant was also approved. So that's a whole different talk. But if you reach a point where endocrine therapy is not viewed as another option, then the things that you can consider are the antibody-drug conjugates. And all three that we currently have available, certainly in the U.S., trastuzumab deruxtecan or TDXD, datopotamab deruxtecan, or even SASI or sacituzumab govitecan, have been demonstrated in clinical trials to benefit patients in this setting compared to what you would normally give patients, which is chemotherapy. So let's look at some of the data, and I'll come back to that in a minute. So one thing I want to get out of the way very quickly is there any role for using antibody-drug conjugates sort of as a first-line therapy? So these are patients who had gotten no prior therapy with chemotherapy. They must have received at least 2 prior lines, at least of endocrine therapy with or without targeted therapy, or rapid progressors, and recurrence less than 24 months of starting adjuvant endocrine therapy plus a CDK4/6 inhibitor. And in this population, patients were randomized 2-to-1 to either receive sacituzumab govitecan or treatment of physician's choice. So as opposed to giving chemotherapy, it was really asking the question, might you use an antibody-drug conjugate as their first cytotoxic? And these are the characteristics of the patients in the trial, and it was very well balanced. Most patients had gotten a CDK4/6 inhibitor before. Most patients had gotten several lines of chemotherapy, at least 1 or 2. And the duration of time on a prior CDK4/6 inhibitor is about 40% of patients less than 12 months, and the remainder more than a year. And this trial did not demonstrate an advantage for giving an antibody-drug conjugate as the first cytotoxic approach in patients with chemotherapy-naive, hormone receptor-positive metastatic disease. So we don't do that. We typically give some line of chemotherapy first, and that's really based on the Tropics study, which we'll talk about here, which was a comparison of sacituzumab govitecan to treatment of physician's choice. And if we really look at this patient population who had previously gotten chemotherapy, you see that there is an improvement in outcome using sacituzumab govitecan over chemotherapy. And again, these are patients who had already gone through endocrine therapy, a line of chemotherapy, and you're seeing an incremental improvement in outcome over what you might achieve with chemotherapy. And similarly, even though this did not really reach what we would think of as a huge difference, 4 months to 5.5 months, there was a statistically significant improvement in overall survival. And that was fairly remarkable, improving things by about 3 months, going from 11 months to 14 months. So there was about a 3-month improvement that was statistically significant using sacituzumab govitecan in this patient population. And the other trial that informs the use of antibody-drug conjugates in this setting is the TROPION-Breast01 study. And again, these are patients with hormone receptor-positive HER2-negative disease, up to 1 to 2 prior lines of chemotherapy, and they had all progressed on prior endocrine therapy, or where they were viewed as not candidates for endocrine therapy for perhaps clinical reasons or some other comorbidity. So in these patients, they either received chemotherapy of physician's choice, which could have been single-agent chemotherapy with eribulin or vinorelbine, gemcitabine, capecitabine, or datopotamab deruxtecan. And what this trial demonstrated was there was a significant improvement in PFS favoring datopotamab deruxtecan, an improvement of about 2 months or a 40% reduction in the odds of disease progression. And although I'm not showing it, if you looked at a forest plot across all the different clinical endpoints or clinical subsets, there was an improvement in PFS. If you look at the time until patients went on to the next therapy after receiving datopotamab, it was longer by about 3 months with datopotamab compared to single-agent chemotherapy. So there was an improvement in that respect as well. There was no real significant improvement in survival, a bit of difference between the lines, but I would submit it's probably not statistically significant. And if you look at the adverse events with datopotamab, you're starting to see that clearly more patients are requiring the use of growth factor support in single-agent chemotherapy compared to datopotamab. There are more patients that have some degree of stomatitis with datopotamab, including about 6% who have grade 3. But again, needs for dose reduction or discontinuation are modest and can be managed for most patients. And the last area, of course, is a drug that seems to be everywhere, and that is trastuzumab deruxtecan. We use it in metastatic disease. We use it in HER2 positive in the neoadjuvant setting. We use it based on DB05. We use it now postoperatively in patients who have residual disease. But we also know that it's an effective therapy in metastatic disease for patients with HER2 low disease who happen to be hormone receptor positive. And the first hints of that came from DB04 and then ultimately DB06. We now have an entity that we refer to as HER2 low as well as ultra low, where there is some level of expression, not zero, and it's less than 10%, where we're thinking ultra low. And then, of course, HER2 low is 1 plus or 2 plus by using H&E staining. So the DB06 trial, which enriched patients for HER2 low disease with about 700 patients, including 150 patients who had that ultra low subset, less than 10%, but greater than zero. And as you know, these were patients with hormone receptor positive metastatic disease. They were chemotherapy naive in the metastatic disease setting, but could have gotten at least 2 prior lines of endocrine therapy, plus or minus targeted therapy, or 1 line in the metastatic disease setting with progression less than or equal to 6 months from starting endocrine therapy plus a CDK4/6 inhibitor, or relatively rapid progression after starting adjuvant endocrine therapy. And patients were randomized 1-to-1 to either receive T-DXd, trastuzumab deruxtecan, or single-agent chemotherapy with CAPE or taxane. And the results were fairly dramatic, with a significant improvement in PFS in the HER2 low population, a difference between the lines of about 5 months favoring T-DXd. You can see that effect was seen across all subsets of patients. We see that whether you're looking at the type of chemotherapy, how many prior lines of endocrine therapy, et cetera, you're not seeing any group that doesn't benefit from T-DXd. And similarly, if you break it down by the objective response rate, patients who received T-DXd did better, and the duration of response also seemed better, with the exception perhaps of the patients with ultra-low disease, where it was very similar, but this might be simply a function of relatively small numbers. And in terms of drug-related adverse events, again, you have to be aware of things like nausea and fatigue, which many patients receiving T-DXd receive. Of course, you do experience alopecia. The rate of neutropenia is somewhat higher, but all of these are manageable side effects for many patients. We're still struggling with how to manage fatigue, but again, most of the other things did not result in significant problems with staying on therapy. Now, the one thing that is true of T-DXd, and we've looked at this in every setting where it's used, is the original observation that a small fraction of patients can experience interstitial lung disease. And in this trial, the fraction of patients who had high-grade ILD or any pneumonitis of any kind was quite low, but it's important to keep in mind that there are still patients who can experience that, and we have to pay attention to any respiratory symptoms that develop. The other thing that we recognize with any anti-HER2 therapy is that we have to pay attention to left ventricular ejection fraction, and again, there were no major issues with T-DXd in this trial. So, how I would think about things where we are right now, again, we're still using endocrine therapy as a first-line therapy. For most patients, it is a CDK4/6 inhibitor with a endocrine agent, usually an aromatase inhibitor, but it could be fulvestrant. There are a certain subset of patients with rapidly progressing disease where a triplet could be considered if they have a PI3 kinase mutation. This is the minority of patients. After which we start looking for particular mutations. So ESR1 mutations become more common. We now have 3 drugs, at least in the United States, that could potentially be used in this setting: elacestrant, imlunestrant, and vepdeg. And then if they have a PI3 kinase mutation, I would submit that capivasertib is probably better tolerated than alpelisib, and certainly the use of alpelisib has fallen off in the United States. It's important to look for BRCA1/2 mutations because PARP inhibitors can be considered. I would probably exhaust endocrine therapy, before going to a PARP inhibitor. And again, there are patients who don't have a obvious mutation where everolimus could still be considered. And we've heard more recent data, such as from the Avera trial, that has looked at one of the new SERDs with everolimus showing benefit. So we'll hear more about that going forward. When patients have exhausted endocrine therapy, we start to get into the antibody-drug conjugates. And as I suggested, we have data from 3 trials showing that sacituzumab govitecan or TDXD or even datopotamab can be considered for these patients. And we'll have other drugs coming. And of course, standard chemotherapy can be considered as well. So I don't know if you want me to go on to the case now or you want to do it at some other point. You want me to do the case?
Oh, okay.
Okay. All right. So I just put a simple case together. Maybe it'll generate some discussion. A 45-year-old premenopausal woman who presented with de novo metastatic disease. She had an intact breast primary. She had sites of disease in the lung, liver, and bone. Biopsy of those areas of the liver as well as the breast showed that she had triple positive disease in the sense she was ER positive, PR positive, HER2 negative by standard measures like FISH, but 2+, so that would, of course, make you think forward that possibly, an antibody drug conjugate like TDXD could be considered at some point. So initially, she's treated as most patients would be with the CDK4/6 inhibitor and an aromatase inhibitor because she's premenopausal. You would either have the choice of doing an oophorectomy or ovarian suppression with a GnRH agonist. She chose the latter. And she had a long duration of benefit from that combination, 24 months, which is similar to what we see in the registration trials. But now she has progression in the liver and the bone. But despite that, her functional status remains good, and her LFTs have not changed all that much. They still remain normal. So there were some new small lesions, and some of the existing lesions at diagnosis had gotten just a little bit bigger, but there was little doubt that she had disease progression. So as I said, LFTs remain normal, performance status is good, and I guess the issue would be what should come next. So one of the things that one would have to think about is certainly doing molecular testing. And I would certainly do that in this case to determine whether or not a patient has a ESR1 mutation or whether they have a PI3 kinase mutation or whether they have both. And if they're still a candidate for endocrine therapy, I would consider, even a SERD with or without targeted therapy if they had an ESR1 mutation, or if they had a PI3 kinase pathway abnormality. This would be a patient who could be considered for capivasertib and fulvestrant. So again, there are several different options, and I wouldn't, since her LFTs are normal or performance status is good, at least in my mind, I wouldn't automatically think this patient has to go to chemotherapy or this patient has to go to an antibody drug conjugate. They could be considered at a later point, but if she had a decent duration of time on her first endocrine therapy, she's probably still endocrine sensitive, and it was 2 years, so she had a long duration. So in my view, this would be somebody I would consider prolonging endocrine therapy. And certainly if she had a truncal mutation like a PI3 kinase mutation, which is probably the driver, I would certainly think about using capivasertib. So those are my thoughts, at least on this patient, and I'd welcome any other comments or questions, and I look forward to the discussion that follows. Thank you.